Welcome to Behavioral Health Today. I'm your host, Dr. Graham Taylor. My guest is Dr. Anthony Salerno. Anthony is a New York State licensed psychologist with over 30 years of public mental health experience in adult inpatient and outpatient clinical and administrative roles. He has been a leader in systems change efforts to promote the adoption of evidence-based practices with the New York City, I'm going to go over that last line here. He has been a leader in systems change efforts to promote the adoption of evidence-based practices with the New York State Office of Mental Health. In addition to direct individual and group treatment services to clients, Anthony has developed multiple programs, including the Wellness Self-Management. This program was designed for adults with serious mental illness, and it received the SAMHSA Science to Service Award in 2010. Currently, Anthony is the Innovation and Implementation Officer at the McSilver Institute and is a senior consultant with the National Council of Mental Wellness in New York, that's in DC. Currently, Anthony is the Innovation and Implementation Officer at the McSilver Institute and is a senior consultant with the National Council of Mental Wellness in Washington, DC. Most recently, Anthony created a resiliency building and trauma-informed psychoeducation curriculum called BRITE, which stands for Building Resilient Individuals Through Empowerment. We're excited to have Anthony with us today as we discuss resiliency and his BRITE program. Anthony, so nice to have you. Thanks for being with us.
Great to be here, Graham.
Great to have you. Hey, when we, as we get started here, I love our listeners to understand what was going on in your life, your professional life that drew you into this work around resiliency.
Well, the way I'd like to look at it, and over these years, I've been in the field for 49 years, Graham.
Nice.
And when I first started out working in an outpatient program, particularly for individuals with serious mental illness, a lot of them coming out of state hospitals, I kind of developed a certain lens. And I like to think of it as the lens that we all use in order to both view the people we serve, the people we help, but ourselves. And I must tell you, my lens at that time emphasized illness, disease, disorder, and dysfunction. And that's what I basically was concerned about, folks coming out of state hospitals in particular. And pretty much every way in which I interpreted or understood the needs and the problems and challenges of folks, I kind of put into the bucket of the psychiatric problem. So I was mostly concerned with, is this person a 294.3 or is this a 194.6? And it was very much dominated by that. And it also influenced how I interacted with the clients, but it also influenced the clients, their perception of themselves, because I reinforced certain things, I inquired into certain things and not into others. So I had that lens for quite a time. And then, what's happened in late 1990s with the adverse childhood experiences work is there was another change in a lens that we ought to pay a lot of attention to the adversity that people experience in their lives. And I have to tell you, I didn't have that. When I was working with clients, I wasn't really inquiring as to what kinds of things have happened to you that may be contributing to your current difficulties. We kind of just put that into the bucket of this is a neurophysiological psychiatric condition, meds is the issue, psychosocial supports, but exploring and helping my clients to understand the degree to which adversity may have been a contributing factor, never got there. Yeah. And, as a recovering Catholic, Graham, I feel really badly about that. I kind of look back and say, I could have been much more helpful to my clients if I had opened up that conversation. So going on from there, when I started to work with the National Council about 13 years ago, my job was to develop national learning communities on trauma-informed care. And as I was doing that, working with organizations, really emphasizing the role that adversity can play in a person's overall health and well-being, it hit me about maybe 5-6 years ago. This is beginning to feel a lot like I felt back in the old days. My lens was still, while it wasn't neurophysiological disorder, it was still life events that contributed to symptoms, dysfunction. And it had that feel to me that I was constantly in this lens of either trauma or dysfunction and disorder. And I said, you know what, there's another side to this. And that's where the issue of resilience came in. So I became very interested in learning as much as I could about this whole field of resilience. And now what I sort of suggest is, or the way I would approach things, is a trifocal lens. I need to kind of appreciate and understand the devastating impact of serious mental illness. I also need to understand and explore the degree to which adversity contributes to current difficulties. But what I also need to explore, which often gets downplayed, is what are the strengths that this person brings to the situation.
That is really good. So easy to get caught up in, what we refer to at times as the medical model. It's almost a secondary and tertiary prevention model. Once someone's already experiencing an illness, now we're going to be going to treat it. And it's easy to get caught up in that. And what I love that you're saying is that if we have that lens, and it's typically an unconscious and usually unintended experience, that we're interacting from what's wrong with you, and we're conveying to the patient what's wrong with me, and they're looking at that as a dysfunctional thing. But what you're saying here is, maybe instead of what's wrong with you, what happened to you, and bringing in, go.
And what happened to you. And also, unless you have a resiliency lens, you are going to miss a lot of the strengths that the person brings to the situation.
Yes,
because your lens is focused on, okay, what bad things have happened to you? And then how do those bad things result in problems that you're experiencing? And if you also have the overlay, what's that?
Yeah, no, the overlay of what? Go ahead, please.
Yeah. And then, so when you focus on that, what it conveys to the client is, gee, things must be pretty bad. My entire life seems to be focused, my identity, my self-concept, because we can reinforce a certain self-concept. And we do it by the things questions we decide to ask,
you bet,
behavior that we decide to reinforce or acknowledge, and especially missing what we may accept, or we may believe is just kind of expected behavior. For example, people with serious mental illness, when they showed up to an appointment, I just thought to myself, well, of course you should show up at an appointment. That's sort of like normal, kind of expectations in a community. What I didn't appreciate, how much courage and energy and effort it took for folks to show up.
Yeah.
The resilience that the person was demonstrating, which I just sort of ignored and just accepted as, well, these are sort of the basic expectations I would have of someone, and not recognizing and appreciating the effort that it takes for many folks to just show up and hang in there. And I could have acknowledged that. I could have reinforced that. I could have strengthened that person's self-concept, as I am capable. There are things I'm doing that they don't even appreciate as being signs of strength. And I think resilience opens up that whole conversation.
I want to unpack resilience in just a moment, but what you're also saying at the beginning of this is that unknowingly, as we're talking, maybe with a medical model or maybe some things that we used to use as questions of inquiry and kind of diagnostic, trying to get some diagnostic clarity, is we're conveying that you're broken. There's something wrong with you. We're conveying something that this is you being broken, and the patient, like you're saying, gets to see themselves as broken, and we kind of become myopic in that, and that becomes our sole definition, and we're not looking at some other things. And what you're raising here is that the adversity piece. Everybody reacts differently to stressful situations, and how you respond to a crisis, depends on our background and our development, our past experiences, our support systems, and even our cultural, upbringings, as well as our perception and our attitudes. And this is what you're kind of leaning into right now: our perceptions and our attitudes about our own perceived control, whether it's internal locus of control or external locus of control. And each of us has our own reactions that's unique to us. And we don't oftentimes go down and take a look at that. But the good news, like you're saying, is that resiliency is something that we can develop. It's a set of skills to manage our life stressors and improve our emotional and our physical well-being. And I know that and what you're emphasizing right now, I know you work from a strength-based perspective, grounding a person in their personal strengths and external resources. And you're emphasizing what's strong in them, not what's wrong with them. I love that on your website. I kind of grabbed that right there. That's a cool emphasis right there. Not what's strong in you, even to get to the appointment. We very oftentimes miss that piece, or just the phone call that they make the very first time to say, hey, I need some help. Can you help me? That's significant. So you're working with patients here, Anthony, to help them that despite their circumstances, there's always areas in their lives that they can control, even if it's just to be in your waiting room and then in your office sitting in your chair. Talk about the importance here of identifying one's personal strengths and the opportunity one has to learn themselves about the practical skills that they may have here already.
Yeah.
That's helping them effectively cope with present and maybe even future life challenges.
Yeah, no, absolutely. One thing I do want to say, like related to this lens idea, and then go into, so what have we learned? What does the resiliency literature tell us, about the kinds of things that individuals do that is likely to sustain their successful effortful coping with situations? And it really comes down to, the writer Anais Nin, who wrote in the 1920s and 30s, there was a line that she had in one of her writings that I think is one of the most profound things in the area of psychology. And you could fit it into a fortune cookie. And it was, we don't see things as they are, we see them as we are. Yes. And I love that. That's a very profound idea that humans kind of like really filter reality through their own particular perception and their own lens. And so when you start to have a lens where you appreciate what we mean by strengths and resiliency, the whole literature, and there's so many resiliency measures, and there's still, debates around what is resilience and all of that. But one of the first things that comes up, and it's very powerful, is the connection to other people. Healthy and strong social relationships is not just a nice thing to have. It is absolutely critical.
It's essential.
And one of the things that I emphasize in my training and supervision of folks is to explore very deeply the degree to which a person is connected to others. Yeah. Because if they are not, if there's isolation, loneliness, right, that is a very serious vulnerability with respect to an individual being able to cope effectively with the typical kind of life challenges you have. That there are many other issues. Having a sense of humor, can you believe it, Graham? Having a sense of humor, as it turns out, is a resiliency strength.
That's our highest. That's actually one of our highest defense mechanisms. Humor.
It absolutely is.
Yeah, it's our highest one.
Yeah, and now you say, well, humor. People go through some horrible things, but individuals who can kind of appreciate the absurdity of life sometimes, right, and kind of poke fun at least some aspects of it, that really can make a big difference. Another very important part of like resilience, and this one I think is kind of challenging, and it relates to the definition of resilience. So one, very, very common to talk about bouncing back, right? This notion of you have a stressor, you have a challenge, you have adversity. It kind of disrupts you in a lot of ways, psychologically disrupting, functionally disrupting, and you want to recover from that process, and you kind of go back to where you were. You were stretched, but you didn't break, right? And you kind of bounce back. The other aspect, which I think is important, if maybe more so, is the idea of bouncing forward.
Yes.
Is that requires, again, a resiliency lens. Instead of just viewing it as these horrible things happen to you, we wish, of course, they never did happen to you, and it's just terrible. And really the focus now is to just recover from that negative experience. A other part of the lens is exploring and discussing with someone, was there anything that they learned through this process? Any lessons, any change in their outlook about life that can actually have a positive contribution? Any way that they tried to deal with it through creative kind of activities that also led the person to make some decisions in their lives. I think of a social work student when I was teaching a class at NYU School of Social Work, and I had distributed the ACE questionnaire to folks just to give them an idea of what that research was about. Well, this particular student decided to fill it out. I didn't ask folks to fill it out. She just decided, I'll fill it out for myself. And then she came to me after class and she says, Dr. Salerno, I decided to fill this out for myself. I have 9 out of the 10 childhood adversities. And that ended up in a 20-minute, 30-minute discussion where it really was a horrendous kind of like experience in her life. All the psychiatric hospitalizations, the substance use, all the kind of adversities and consequences that's associated with severe adversity in life. But what she also said to me was really amazing. He said, and she was doing very well in School of Social Work. She says, I've decided to devote my life to helping, especially little girls, who have gone through and have experienced some of these difficulties I have. She brought meaning to that event.
Right.
The absence of meaning is sometimes as difficult to deal with as the actual adversity itself. When you have a sense of there was nothing, I discovered nothing through this. I didn't learn through this. I didn't develop any greater empathy towards others. I didn't decide on a particular life role path based on that kind of experience. I didn't develop any creative activities or approaches to deal with it that I can now see value in. The absence of meaning, and they talk about that in the literature, the idea of meaning making. I think that's a pretty important thing. And to not be fearful of starting that conversation with somebody, to explore the degree to which there has actually been some growth through adversity. And I think that that's an important concept that I think often escapes folks out there.
I really appreciate that lens as well, because, you know, we could say that resilience is actually ordinary, meaning it's not extraordinary. It's commonly demonstrated. This gal is in a master's level program, it sounds like. She went through all those 9 of the 10 and she's still there. She had to do something along the way, but it's not oftentimes recognized. And if we're using the old, kind of the old lens, well, how are you broken? Then you tend to stay broken and small. But what you get to do with this young lady, is you say, how did you get here? What were you doing that was such a resilience, and what kind of meaning did you make? And what you're also saying too, we think of, Kubler-Ross's, stages of death and dying, and it can be applied to a number of things. And just use as a quick model, we get down to this place of acceptance after going through anger and depression and acceptance. But there's this other level that they've added here where there's a transcendent piece to it, where you actually transcend your experiences. You're not defined by them, but you are influenced by them, and you actually transcend them. It's almost like the Navy SEALs too. You were talking about this idea of bounce, and I like what you're saying is bouncing forward. The Navy SEALs put guys and gals through some really horrendous things, and they think that they are this kind of person when they come in, and these are my abilities, and then they push them a little bit more, and a little bit more, and a little bit more. And they thought that this was who I was here, but really who I have the capacity to be is really this person here. And they never saw it before until they did it. And what you're emphasizing that I love is that folks have a lot more bounce, strength, resilience in themselves than they oftentimes really see. And when we begin to kind of hold this up to them, we get to mirror the mirroring relationship growing up is so essential. And the mirroring relationship in a therapeutic relationship is even sometimes more essential, because we get to hold up a healthy mirror. And now we're saying, take a look at yourself. And they're going to go, wow, I never saw this, but thank you for pointing it out. I'm larger and stronger and more capable than I thought I was.
Yes.
I love this approach.
No, absolutely. You make a very, very good point. This issue of meaning, finding, the strengths. And when you said normal, what you really mean is, and the people in the resiliency literature, many would say that it's the default. What you should expect is resilience.
Exactly.
That's the default. And if there isn't, then there are some factors that may be contributing and disrupting what is a kind of built-in human response to challenge.
Very well said.
That we're really doing. So that's, I think, a really good point that you've emphasized. Absolutely.
Yeah. And what you're saying right here is that maybe they haven't had, some of the people in their lives to hold this up. Maybe, with the breakdown of the family, with the breakdown of, things, community organizations that we've typically had, and the isolation that's taking place for a number of reasons. People don't have these mirrors. People don't have this community. They don't have these kinds of relationships that can kind of buoy them up or say, hey, let's hang in there. Let's see how we can grow, being expectant around adverse, difficult times. And as we're talking about this, you're talking about the ability to adapt well. And we might even say it's just inherently there, but we need people around us to do it. So we can adapt well in the face of adversity or trauma or tragedy. This gal in your classroom did. And you're holding that up to her and saying, hey, you're doing a great job. And she's devoting her life to this through creating meaning through it.
Absolutely. Folks at Columbia, Dr. Yehuda, she has an interesting way of describing, what is resilience from her perspective. And basically the point she takes, she actually used the analogy of the Timex watch. And for some generations remember that. But the idea that the watch, that was the great advertisement, was that the watch took a licking, but it kept on ticking, right? And her view is that even if I see patients who have serious PTSD symptoms, that is not the failure of resilience. The failure is when a person gets stuck, when you stop ticking. As
Really
long as,
good.
and there are many individuals who are really struggling with some very, very serious emotional difficulties, and yet they get up in the morning and they kind of go to work, or they take care of kids, or whatever it might be. And it's sort of like just recognizing that is appreciating that, right? That through those sort of like difficulties, folks don't need to be symptom free.
No,
What happens if you define resilience as the person is no longer experiencing some serious difficulties, then you're going to wait around when to a situation that's less likely to occur, and you don't enter into the conversation of helping the person to recognize strengths. In many ways, this is in healthcare too. It's not so as much, sometimes it's the treatment gets you better, but many physicians would say it's your health that gets you better. It's your strengths that get you better.
right.
Our treatments can only go so far, but if you have a healthy lifestyle, if you have healthy nutrition, to appreciate and recognize is that it's your strengths that get you better, not your weaknesses. And how do we emphasize that, identify, and then build our services around the strengths as opposed around deficits? That's another implication of having a resiliency lens.
This is such a beautiful reframe that you're bringing in here. This idea, these things we can control, but oftentimes, if we don't have significant others in our lives helping us see it this way, we just don't inherently know to look at these things that way.
Right.
And this capacity to make, realistic plans and take steps to carrying them out, or developing a positive view of oneself, or the ability to, like you're saying, to see their strengths and their abilities, even out of adverse times. Somehow, basically what you're saying to them, you've survived all of your worst days. Do you realize that? You survived all of your worst days, and look at you.
Yeah.
How'd you do that? So you're helping them develop this. Now, I also know that part of this is learning how to identify these things and teach these things. And that's part of what you do through your BRITE program, building resilience, individuals through empowerment. Talk to us about this program and your lessons.
This is what sort of happened. So when I mentioned to you about 6 years ago, getting this kind of an epiphany, why it took so long, I don't know. And then I said, okay, it must be out there. There must be, there's a whole set of trauma treatments, right? There's a whole set of them out there. But I said, there must be some resiliency focus, resiliency building, curriculum, programs, strategies, all that kind of thing. So I went out to kind of like look, and I didn't find anything. So I said, what am I going to do now? Because I think this is really important. So I tried to see if I could get some sponsorship, but it didn't work out. So I turned to my wife one morning. It was like Sunday. I said, Louise, I'm going to do it myself. And she said, well, rather than do that, how about we go out to brunch? Well, I know. I said, but I just, sometimes I get this. Like, I'm in the twilight of my career, Graham, and it's going to be my last oomph in my life. And it really is around promoting, discussing, sharing, and keeping the conversation around resilience going. And so, I have a history of using structured educational material, because I do believe that part of almost all effective treatment is imparting information to an individual so that they can make more informed decisions about their lives. And if you haven't got that information, you have power. You don't have power. You know who has power? People who do have that information. And I think there's a lot of the work that we do, especially with individuals with serious mental illness, where very much they're reinforced to be in a very passive type of position and don't have the information and strategies to take greater charge of one's own treatment. So I had developed material called Wellness Self-Management in New York State, and that's still going on after like 15 years. People are still using that. And I thought to myself, perhaps I can build on that approach and develop something that's focused on resilience building. And so I developed it into a 24-lesson program that reflects a lot of what the literature was suggesting that would be important in terms of building resilience. So the kind of information that people need to know. If you don't know it, right, you don't have that information or knowledge, and you don't have strategies to actually do anything with it, you're in a weakened position. The last thing people who are struggling with serious mental health issues need is to be in a disempowered state. And I've worked with a lot of consumer advocacy groups in New York State over the many years. And that's one thing that I have certainly learned. The perspective is a really supportive system is one that empowers us to make informed decisions about our own health and well-being. So I decided to just put it together. It took me about 3 years. And I've been training folks around the country on on really using these materials in a way to impart information. Because think of it, Graham, how would you impart information about, you know, what we mean by resilience? What are some of resilience strengths? If you were trying to do it through conversation, it would be very hard. Verbal information processing is often not the strongest kind of cognitive capacity of people, particularly with serious mental health problems. But that's what, I mean, we call it psychotherapy and counseling, but it's conversation, right? And so if you want to impart information, I should have thought about this because I used to be a high school teacher and a school counselor.
Yeah.
And I wish I had kind of kept that role perspective in my head that I could have applied when I went to more of a clinical psychologist type of like setting. And so I developed these materials. I did some initial piloting in New York City. Organizations were willing to give it a try. And I met with all the clients and the staff through focus groups. And I remember one particular situation. It was a men's shelter. And it was for men who serious mental health, substance use, and also criminal justice involvement. And there was both a peer and a professional who ran this group. It could be done in a group. BRITE program can be as a group with a select group of sessions. You can pick and choose which lessons or topics you think are really pertinent, or you can do it with individuals and you can pick again and choose which aspects make most sense, because it's a resource. It's not a prescriptive treatment intervention. It's a resource that practitioners, organizations, and clients use in order to increase their ability to really make informed decisions, have more power. So when I was interviewing this focus group of 9 men, and one man turns and says, well, let me just tell you something here. And these were pretty tough guys, right? Who've been through a lot. Says, you know, there's a lot of stuff I went through in my life. And this guy was probably in his mid 40s. He said, I never told one therapist about any of it. I never told anybody about what I was going through. But, you know, with this group, I told my brothers about things that happened to me that I was so upset about, feel so ashamed about, but I never told anybody. And the peer counselor and the therapist, the professional counselor and the peer were kind of really reinforcing that of sometimes these structured educational programs create a degree of safety and comfort, and the cohesion that builds the safety, because I think that's extremely important. Safety and control. People who've been traumatized, the two things that you cannot compromise is safety and a sense of control. And the material was designed to promote safety and a sense of control. Nobody pushes you. You go at a pace that feels right for you. You're never going to feel pressured or coerced, even in a subtle way, to say or do anything that you don't feel comfortable with. That created the kind of opportunity for a man like this to be able to share with, interesting, he called them his brothers, in this particular, group. And that just reinforced for me, like, maybe we're on the right track with this. I wasn't sure when I did the pilot whether or not folks were going to really respond. And folks responded really very well. So that's a lot of my work these days with the National Council, is offering trainings to organizations around how to, if one of your goals is to engage folks in learning about the role of trauma and adversity in life, to strengthening their resilience, to impart that information. If that's part of your work, then BRITE could be a helpful resource in that work, rather than having to kind of figure this stuff out yourself, because the workforce is pretty burdened as it is.
Yes.
And to expect them to kind of figure this stuff out is going to be quite a challenge for folks. And I love training, practitioners, investing more in the workforce out there. They need a lot. They need tools. They need resources. They need a really practical, practical tools that they can apply, and doesn't require an excessive amount of burden on their learning, on their application. And the BRITE provides you with a lot of guidance. And so far, I've been really gratified by the response of folks.
I can certainly imagine you would be. These 24 lessons have some of the greatest topic areas. Again, things that we can learn, sometimes things people are already doing that they don't recognize, that they
Right.
can enhance and even grow more. There's capacity, again, for setting realistic goals, communication, problem solving abilities, the capacity to manage strong feelings and, impulses, and to be in control, that kind of our EQ type things. And these are things that we can develop that I really think are so applicable and so easily attainable through this program, the way that you so nicely laid it out. Really, really nicely done.
Well, you'll notice, Graham, is that every lesson is designed to pull for a person's strengths.
Yeah.
I'm kind of obsessed with strengths.
Yeah.
And I think that we as a profession ought to be obsessed with strengths.
Yes.
I'm sure you remember, Graham, that in a case study or case conference, the really smarty pants psychologist was the one who could find a disorder that other people missed. Oh, you guys missed this disorder. You guys missed the compulsive obsessive features. Oh, you guys missed the narcissism. But it wasn't very common for a psychologist to say, hey guys, let me tell you about the 10 strengths that you guys missed in this. So I think the system has shaped our lens. I'm kind of a psychological optometrist these days, Graham, of really corrective lenses. And the system shapes our lens, our training shapes our lens shapes us, our lens shapes our clients. And we need to sort of appreciate that. And what can help us to develop a lens that gets a little closer to reality, right? Yeah. So that we see things as they are rather than as we are.
That is definitely going to be your legacy. This guy was the psychological optometrist that came in and kind of gave us a different prescription here. And I think you're so right around, the research around reinforcement is huge. And those things that we reinforce, those things that we reward tend to get repeated. But we're so used to catching people being bad. We see our kids, hey, what are you doing? So we correct them. But if you can, unless they're going towards a brick wall or doing something really egregious, we say, hey, and we can catch them being good.
Yeah.
They're going to respond to whatever we reinforce. So, hey, you guys are playing so well with each other, and just deposit that, let it go. Or what an awesome job this team has done, in creating this product. Well done. Those things that we reinforce are going to get repeated. And those things are not so ideal. If we don't give them attention, unless they really require some specific, attention, they're going to extinguish themselves because they're going to be replaced with all of these strengths that you're describing and these abilities where someone can grow into this person that maybe they hadn't fully realized before that they had the potential to do. And that's what you're emphasizing so beautifully with this lens.
Yeah. I mean, I think that it really comes down to that. And it also is this certain mindset that you bring to the work. So one of the things that I emphasize is to appreciate that each person is doing the best they can in light of their biological vulnerabilities, in light of their life circumstances, in light of the resources that they have or don't have, and which is important to mention because resilience is not just an internal factor.
Yes.
Resilience is very much affected by the presence or absence of supports and resources in the environment for the individual, which I think is it's a very important issue to recognize that we're not just talking about what resides inside a person. I get into spirited conversations with folks who say, Tony, I don't like this resilience stuff. I said, well, how come? I said, because you can end up blaming the victim, right? And I'm saying, I get that. But to recognize resilience, that it's a much more comprehensive factor that is a very clear interplay between a person's personal characteristics and strengths and the resources and supports in an environment. And they need to be taken together. Otherwise, you may run the risk of viewing resilience as exclusively an internal factor, and it is not.
Right. No, there's a lot of layers to it. And what I like that you're saying here too, and this is a really key piece, with our adverse experiences in life, and typically, those happen before, the majority happen before they're 18. That's what the ACEs focuses on. We don't have oftentimes in our environments, people, to right size those experiences. So what do we tend to do? We haven't got a frontal lobe that's about planning, judgment, reasoning, organization, all those things that kind of help us understand what's going on. So we tend to be, as we're growing up, pretty emotionally, driven by most things. And so when something bad happens, what do kids do? Well, since they're kind of egocentric, they tend to create meaning that this must be about who I am. It's a shame-based, fear-based message.
Oh, right.
And
Right.
what you're doing here with the resilience is you're replacing shame and a negative self-meaning with a sense of, hey, you survived those things. Those things happened to you. You weren't responsible for them, but you somehow not only, you survived them. Look at that strength. And so when these things didn't happen, they weren't, shame is about who we are, not what we did.
Right.
These things happen because of who I am. And you're saying, no. These things happened to you,
Yeah.
but look through your resilience, how you survive them. Look at those strengths. And it's almost like there's going to be this emergence of, I would imagine, a different sense of who that person is, replacing that shame with a strength, with a sense of, wow, I actually am pretty empowered, aren't I?
Yeah. And it protect, you know what it does? It ensures that we don't get into a lot of judgment.
It's inoculating against that, isn't it?
Yeah, it is inoculating against that. It's really understanding.
Yeah.
It's a lens that says, look, this person in front of me is doing the best they can in light of biological vulnerabilities, life circumstances, resources, all of the things, right? That what their own educational background has been, the coping strategies. It's kind of like an acceptance of the individual,
Right.
that they're doing the best they can in light of all of these factors. But now they have me. Now I'm now part of the system, and recognizing what is it that I can do that can be a support, because I'm not inconsequential here. I've now entered that person's life sphere.
Yes.
And that what it does is you're less likely to judge. And I, as a physician, I remember a physician saying, I think of addiction differently now. This is a person who got educated around trauma and resilience, and said, I kind of look at it more like it's kind of ritualized, compulsive comfort seeking. Comfort seeking? Now, do you think about drug use as comfort seeking, or as a really completely understandable strategy to cope with maybe the experience as overwhelming anxiety or distress or whatever it might be, is to kind of like recognize that even the things that are dysfunctional may represent the person's best effort in light of their life circumstance, best effort to manage unmanageable or overwhelming experience. That brings, I think, a sense of a level of compassion, a non-judgmental attitude. And I think that the client experiences that, a sense of acceptance, even in the presence of behavior or, strategies that are, may seem to work in the short run, but really are kind of disastrous in the long run. But that sense of, and could you imagine, I want the client to go away saying, I don't know what it is with this Dr. Salerno or this Dr. Taylor, but they seem to really want to understand my perspective. They really want to understand. And they also don't seem to judge me very much. Even when I screw up stuff. And you know what? I can tell them anything, and their face is not going to grimace with disapproval. That takes a lens of acceptance, and resiliency, I think, supports that kind of lens.
Yeah, that's well said. Well said. I love that idea of comfort seeking. And what you're getting them to see now is maybe they can seek true and lasting comfort in their ability to be resilient and what they survived, and to see that that's where their comfort gets to come from now, within, internal, not external.
Exactly.
I think you and I could go on all afternoon here today, but
so.
I'm gonna shape this a little bit here. So let's give our listeners some opportunity to follow up with you and your BRITE program when they're done listening for today. How can people get in touch with you, Anthony?
Yeah, the best thing is to actually go to my website, which is BRITE Resources. It's BRITE resources.com. And they'll get a sense of what the program is. They can check out some of the sample lessons. I actually am adding additional lessons because I get requests. One organization worked with folks in criminal justice, and they said, hey, Dr. Salerno, you think you could put together something for folks who've been involved in prisons and in jails, so that they can appreciate or recognize the degree to which some of their behavior that's associated with criminal justice involvement may have its roots in some adversity. And then also, what is the resilience part of it in terms of people integrating back in the community? So I created a lesson around that. So I keep adding lessons to the website. And then also it's been translated into Spanish recently. And so that'll be
Fantastic.
available as well. So going to that website will pretty much give people a really full understanding of what it is. And then they can decide whether or not there's something for them and they would like to explore and discuss further.
Very good. As I'm listening today, I know you've been a little hard on yourself around this idea of I'm only coming to this now. And I get as a clinician that oftentimes we're cutting our teeth in our profession, wishing we had known then what we know now, and kind of,
Absolutely.
retrospectively, we kind of go, boy, this
Yeah.
could have been helpful. But you know what? What a wonderful legacy you're living, or leaving rather, living also, but leaving, in this twilight of your career. What a great piece to be leaving us, as clinicians and our future colleagues behind us coming up in this wonderful curriculum. So really nicely done, and congrats on that. And it's been great to be with you today, Anthony.
Terrific. I really enjoyed this a lot, Graham. And also some of your comments has gotten me to think a little bit more about this as well. So I appreciate that.
Fantastic. Well, thank you again. I also want to thank you, our listeners, for dropping by and joining Anthony and me today. It's always great to have you with us. Regarding our episode today, I want to remind you that it and an archive of all of our other resources and episodes can be found on our webpage at triadhq.com/BHT. Thanks again for being with us on the show. And we'll look forward to having you back with us next time on Behavioral Health Today.